obesity, or it lies about 10 to 13 centimeter lateral to the umbilical. So here I am using a small blade and make a 15 number blade and make a 2 and 2 knit. And here the beauty is that we do not lift the abdomen and we go absolutely perpendicular. Can you see here? Yes, ma'am. Yeah. So very important part. Very important. So because if we go immediately, then we can go closer to the sacral promontory. And if we remain absolutely vertical, it is perfect. So now we try to appreciate layer by layer as we reach. So the external oblique and the internal oblique transversal fascia energize when it reaches the abdomen. But how many entries you would have done in your lifetime? Every entry is always important. So I always carry out first the pneumoperitoneum, first the drop test. So we are using a disposable needle where you can see the drop going in. Hope you saw the drop going in. Yeah. So now only we will turn the pneumoperitoneum on. So which need to be have as an insufflator? Only that. So what is the earlier? Well, we cannot see. So it's very important to keep an eye over the insufflator, for the initial insufflation should not be more than 6 to 8 millimeters mercury. What does it show? No, this is the flow. What is the millimeters of mercury here? कितना प्रेशर है आप बताएंगे? So I'm asking you the. It's not showing how much it is. So anyway, we are quite used to the fast food of a cycle insufflator, which can easily show you the initial. Yeah. So we are getting a uniform insufflation. So after we are done there, then and normally we are going for 3 liters before we insert the first trocar, the 5 mm trocar. The technique is that we first insert it to the 5 mm, and do we have a small telescope? 5 mm? Okay. So the only thing is that we need to have 2 telescopes. So here we use, like we did the cystoscopy and we injected ICG. So we already need a small caliber scope, and the same small caliber scope can be used for entry for the vein point. So we just wait a little more. So vein point has its benefits because it is far lesser from the umbilical. So for experienced surgeons, it is good to avoid adhesions in big masses. Is good that we do not enter or hard perform the mass, the cyst or the myoma directly. And for beginners, you see, because it is so much away from the umbilical, so there is no risk of major vessel injury. So that is many times when trainees come, not in these years, in the earlier years, they have quite a big phobia of first entry to the umbilical. Maybe in some years. So we will be watching you, ma'am. That was a wonderful demonstration. So can I have Dr. Rajesh Modi? Because he can just 1 minute. Shall I enter the एक रिक्वेस्ट है फ्रॉम द ऑडियंस कि आप एक बार जैन पॉइंट दोबारा दिखा दोगे. Some of them had missed out or they had moved. So I just do like this. And this is the NPS file. Is it clear? ASIS. We move 2.5 centimeter medial. We draw a vertical line, and then we draw a horizontal line at the upper margin of the umbilical. When these 2 points are there, that is the vein point. So first we enter with the vein. After pneumoinsufflation, then we go with the 5 mm trocar. Then we wait for the hip, and now we will go with the 5 mm telescope and see that where are the adhesions and how this entry point has started. Ma'am, can we have the insert picture now? Yeah, please give the insert picture. Or can you give PIC?
Yeah,
Yeah,
basically,
continue with you in the PIP. Dr. Modi will finish his case. So
Ma'am,
we will
yes.
go back to the first to second.
yeah, we
Okay,
can.
sure.
Thank you. Dr. Modi, you are live and audible in auditorium.